Good day everyone. Thank you for coming. I am Paul. I will be doing a voice-over lecture created by Dr. Donaldo Tugbang. Today's course lecture series is about sleep physiology and sleep-wake disorder. The main objective for this lecture series is to provide a basic knowledge and understanding about the neurophysiology of sleep and its associated pathologic conditions. So, what do you know about sleep? Sleep is a universal behavior that has been demonstrated in every animal species. It is one of the most significant of human behaviors, occupying roughly 1/3 of our lives. From a behavioral standpoint, it is a state of decreased awareness of environmental stimuli that is distinguished from states, such as coma or hibernation, by its relatively rapid reversibility. It plays a vital role in good health and well-being throughout your life. Getting enough quality sleep at the right times can help protect your mental health, physical health, quality of life, and safety. In children and teenagers, sleep also helps support growth and development. Why is sleep significant in medicine? Sleep is particularly relevant to medicine because sleep disturbances occur in most medical and psychiatric illnesses. In fact, sleep and mental health are closely connected. Sleep deprivation affects your psychological state and mental health. And those with mental health problems are more likely to have insomnia or other sleep disorders. In addition, chronic sleep problems affect 50% to 80% of patients in a typical psychiatric practice, compared with 10% to 18% of adults in the general U.S. population. Sleep problems are particularly common in patients with anxiety, depression, bipolar disorder, attention deficit hyperactivity disorder, and other medical illnesses. The electrophysiology of sleep. Sleep is composed of two physiologic states. Non-rapid eye movement or non-REM, which is further divided into 4 stages. Non-REM state is characterized by markedly lower brain activity and physiologic functions than in awake state. It is called orthodox sleep or quiet sleep in children. The other one is rapid eye movement or REM. Its brain activity and physiologic functions is higher or almost similar to awake state. It is also called paradoxical sleep. Sleep is typically scored in epochs of 30 seconds, with stages of sleep defined by the visual scoring of 3 parameters: the electroencephalogram, electrokilograph, and the electromyogram recorded. Here is an illustration of a human stage of sleep and wakefulness noted in the EEG. During wakefulness, where a person's eyes open, the EEG shows a low voltage, fast activity, or activated pattern. Beta activity, about 18 to 25 cycles per second, is prominent. Voluntary eye movements and eye blinks are obvious. When the eyes are closed, in preparation for sleep, wherein the person is drowsy and relaxed, alpha activity of 8 to 13 cycles per second becomes prominent, particularly in occipital regions. Non-REM sleep follows. This is divided into 4 stages. Sleep enters a transitional state, known as Stage 1 sleep. In Stage 1 non-REM, it is characterized by loss of alpha activity, with the appearance of a low-voltage mixed-frequency EEG pattern of prominent theta activity, of 3 to 7 cycles per second, and occasional vertex-sharp waves. Eye movements become slow and rolling, and skeletal muscle tone relaxes. Subjectively, Stage 1 may not be perceived as sleep, although there is a decreased awareness of sensory stimuli, particularly visual, and mental activity. Motor activity may persist for a number of seconds during stage 1. Occasionally individuals experience sudden muscle contractions, sometimes accompanied by a sense of falling or a dreamlike state. Hypnic jerks are generally present but benign, and may be exacerbated by sleep deprivation. After a few minutes of stage 1, sleep usually progresses to stage 2, which is noted by the appearance of sleep spindles, 12 to 14 cycles per second, as well as K-complexes, which are high-amplitude, negative sharp waves. This is followed by positive slow waves in the EEG. Stage 2 and subsequent stages of non-REM and REM sleep are all subjectively perceived as sleep. Stage 2 is generally followed by a period of stages 3 and 4. Slow waves which are less than 2 cycles per second in humans appear during these stages, which are subdivided according to the proportion of delta waves in the epoch. Stage 3 requires a minimum of 20% and not more than 50% of the epoch time occupied by slow waves, whereas stage 4 is scored with greater than 50% of the epoch showing slow wave activity. Stage 3 and 4 are also referred to as slow wave sleep, delta sleep, or deep sleep, since arousal threshold increases incrementally from stages 1 through 4. Eye movement ceases during stages 2 to 4. When persons are aroused 30 minutes to 1 hour and after sleep onset, usually in slow wave sleep, they become disoriented, and their thinking is disorganized. Brief arousals from slow wave sleep are also associated with amnesia for events that occur during the arousal. The disorganization during arousal from stage 3 or stage 4 may result in specific problems, including inersis, somnambulism, and night terrors. On the other hand, REM sleep is not subdivided into stages, but is rather described in terms of tonic or persistent, and phasic or episodic components. Tonic aspects of REM sleep include the activated EEG similar to that of stage 1, which may exhibit increased activity in the theta band, which is 3 to 7 cycles per second, and a generalized atonia of skeletal muscles except for the extraocular muscles and the diaphragm. While in the phasic features of REM, it includes irregular bursts of rapid eye movements and muscle twitches. Persons awakened during REM sleep frequently 60 to 90% of the time report that they had been dreaming. Dream during REM sleep is one of the most distinct feature in this stage, and usually is described as abstract and surreal. Dreaming does occur during non-REM sleep, though in some cases, is uncommon, and it is typically lucid and purposeful. So, how is sleep regulated? Sleep is a dynamic process involving complex neural activation. In 1929, the psychiatrist Hans Berger established that brain activity was different during wakefulness and sleep by recording cortical electrical potentials, which is currently known as electroencephalogram or EEG. Up to today, understanding of the control mechanisms of non-REM and REM sleep continues to develop. The ascending reticular activation system is composed of neural circuits connecting the dorsal part of the posterior midbrain and anterior pons to the cerebral cortex via distinct pathways that project through the thalamus and hypothalamus. Neurons of the reticular activating system are central to the regulation of wakefulness. The ascending reticular activation system has two pathways. 1. A dorsal route from the cholinergic lateral dorsal and pedunculopontine tegmental nuclei, which activates the thalamic neurons to promote cortical activity via glutamatergic thalamocortical projections. 2. The ventral route through the hypothalamus via signals, which is primarily composed of 4 main components that contains grouping of nuclei originating from the brainstem. These signals come in the form of chemicals called neurotransmitters, Each is unique in the neuropeptides they release. When neurons in the arousal areas are active, the cortex remains activated and we stay awake. The following group of nuclei are involved. A. The locus coeruleus is located within the upper dorsolateral pons of the brainstem. It is activated directly by orexin from the lateral hypothalamus, and in response, releases norepinephrine. Its excitatory functions are widely distributed within the brain, acting on both the alpha and beta receptors of neurons and glial cells distributed throughout the cortex. It functions primarily upon waking and in arousal. B. The ref nuclei are located midline throughout the brainstem within the pons, midbrain, and medulla. The majority of neurons located in the ref nuclei are serotonergic. The more rostral ref nuclei appear to be important in various bodily functions, including pain sensation and mood regulation. In the context of the RAS, these nuclei communicate with the suprachiasmatic nucleus, playing a role in circadian rhythms, and contributing to arousal and attention. C. The tubermammillary nucleus is located within the posterior aspect of the hypothalamus. The neurons that make up these nuclei are primarily histaminergic and serve as the primary source of histamine projections in the brain. They are important in both wakefulness and cognition, projecting in large part to the forebrain where they play an important role in arousal. D. The lateral and dorsal pedunculopontine tegmentum contains primarily cholinergic neurons in neighboring groups within the midbrain and pons. Cholinergic neurons project to the thalamus and cortex, promoting desynchronization of the brain, allowing the body to switch from slow sleep rhythms to high-frequency, low-amplitude wake rhythms. Cortical activation during wakefulness is also influenced by orexinergic or hypocretin neurons, originating in the lateral hypothalamus. It provides excitatory input to all ascending reticular activation system components, as well as cholinergic neurons from the basal forebrain. During wakefulness, these pathways allow sensory information or signals to be transmitted to areas of the association cortex via the thalamic gate. It should not be surprising that transection of the brainstem at the level of the midbrain interrupts all of the fibers in the ascending reticular activation system and results in an indistinguishable state of non-REM sleep. Drugs such as amphetamine and cocaine, which enhances the release or synaptic concentrations of dopamine and norepinephrine, dramatically enhance and prolong wakefulness. Nicotinicholinergic agonist, and anticholinesterase inhibitors, for example, neostigmine, have long been known to enhance arousal. A number of other neurotransmitters and neuromodulators appear to have wakefulness-promoting effects. These include substance P, neurotensin, epinephrine, and hypothalamic peptides such as corticotropin-releasing factor, vasoactive intestinal peptide and thyrotropin-releasing factor, all of which can increase arousal levels. Cortisol also promotes wakefulness. It is thus possible that sleep disturbance in depression, including early morning awakening, could be related in part to the associated hyperactivity of the hypothalamic pituitary adrenal axis. The initiation of non-REM sleep begins with the emergence of inhibitory signals from the ventrolateral preoptic area. The preoptic area lies just rostral to the optic chiasm. The ventrolateral preoptic neurons are sleep-active in that they increase their discharge selectively at sleep onset. It also contains GABA and project to serotonergic, noradrenergic and cholinergic cell groups in the brainstem reticular formation, while histaminergic in the tubermammillary neurons located at the posterior hypothalamus. These wake-promoting neurons in the brainstem show progressive reductions in activity across sleep stages. These neurons show progressive activation, which eventually induces inhibition of the wake-promoting neuronal cells associated with the ascending reticular activation system. Therefore, A sleep process starting with activation of the ventrolateral preoptic region would inhibit wake-promoting systems, thereby facilitating the sleep onset process. On the other hand, an arousing input mediated by wake-promoting neurons would inhibit the ventrolateral preoptic neurons, which would then remove inhibition from wake-promoting neurons. In this way, the system can switch decisively between sleep and waking, and also tend to maintain sustained sleep and wake states. The ability to remain in a stable period of sleep or wakefulness is a result of mutual inhibition between the wake-promoting neurons and the sleep-promoting neurons, which is an all-or-nothing process. So in short, the areas of the brain that maintain wakefulness by activating the cortex also inhibit ventrolateral preoptic area neurons. Conversely, when these neurons fire rapidly and induce sleep, they also inhibit activity in the arousal centers such as the tuberomammillary neurons. In addition to inhibition of the ascending reticular activation system by the ventrolateral preoptic neurons, other regions of the hypothalamus and forebrain participate in non-REM sleep. In particular, the anterior hypothalamus, preoptic area, and nucleus bustless all contain GABAergic neurons that project to cortex and participate in the control of non-REM sleep. GABA has long been thought to play a role in sleep, particularly in view of the sedative effects of the benzodiazepines such as Valium, which are known to enhance the postsynaptic action of GABA. Transitions between these stable states of wakefulness and sleep occur relatively quickly, often in just seconds. Some researchers have compared the neurological mechanism that controls these rapid transitions to the flip-flop switch in an electrical circuit. During REM sleep, there is activation of cholinergic neurons in the laterodorsal and pedunculopontine tegmental nuclei. This cholinergic activation occurs when there is withdrawal of the bioaminergic arousal systems, noradrenergic neurons in the locus coeruleus and serotonergic neurons in the dorsal raphe nuclei produces disinhibition. This causes the release of acetylcholine, which triggers the increased neural activity that is a feature of REM sleep. Suppression of motor activity, the other marker of REM sleep, is generated by glutamate-mediated activation of descending medullary reticular formation relay neurons. The activity of these neurons is inhibitory to spinal motor neurons via the release of glycine and to a lesser extent GABA. People generally require several minutes to calm down and relax enough to fall asleep, and the deepest stages of sleep typically occur 20 or more minutes after sleep onset. However, sleep onset and associated loss of consciousness can occur in an instant. This is particularly obvious in very tired people who can fall asleep at inconvenient and sometimes dangerous times, such as when driving a car. Waking up from sleep can occur very quickly, for example in response to an alarm clock, although it typically takes people much longer to become fully alert after awakening. There are many internal factors such as homeostatic sleep drive and circadian rhythms and environmental factors such as noise that influence the likelihood of falling asleep or waking up. For example, a powerful sleep drive builds up with prolonged wakefulness and shifts the balance towards sleep. How this occurs is not precisely known, but adenosine is one of the chemicals thought to accumulate during prolonged wakefulness. When it does, it serves to induce sleep by inhibiting wake-promoting neurons. On the other hand, caffeine inhibits the actions of adenosine and therefore helps maintain wakefulness. The timing of transitions between sleep and wakefulness are also tied closely to the body's internal biological clock. Biological clocks produce circadian rhythms and regulate their timing. The structure regulating this is the suprachiasmatic nucleus. This tiny structure is made up of approximately 50,000 brain cells which receives light signals directly from the eye, through the optic nerve. Light resets the clock to correspond to the day-night cycle. In turn, the clock regulates the timing of dozens of different internal functions, including temperature, Hormone release, particularly melatonin, which is secreted by the pineal gland in response to light-dark signals and sleep-wake cycle. This nucleus promotes wakefulness by producing a powerful alerting signal that offsets sleep drive. It also promotes sleep by turning off the alerting signal. In addition, it actively maintains sleep throughout the night even after sleep drive has dissipated in the second half of the night. Here is a table summary of the physiologic changes associated with sleep stages. During non-REM sleep and tonic REM sleep, there is a relative increase in parasympathetic activity relative to sympathetic activity. The autonomic nervous system reaches its most stable state during delta sleep in comparison to wakefulness. During phasic REM sleep, however, there are brief surges in both sympathetic and parasympathetic activity, resulting in a high degree of autonomic instability. Blood pressure, heart rate, and cardiac output decrease during non-REM sleep. Arrhythmias are also more prevalent in REM sleep. Temporary breathing instability and/or periodic breathing may occur at the onset of sleep. Respiratory rate and minute ventilation decrease during sleep, and upper airway resistance increases as a result of muscle relaxation, most significantly during REM sleep. These changes contribute to exacerbations of underlying pulmonary disease as well as sleep-related breathing disorders such as sleep apnea. Brain and body temperature are down-regulated during non-REM sleep, as a result of a decreased hypothalamic temperature set point as well as active heat loss. People commonly experience this phenomenon when they go to sleep feeling somewhat cold and wake up several hours later to throw off their extra covers because they feel too warm. During REM sleep, there is a decreased ability to regulate body temperature through sweating and shivering. Most hormones show significant interactions with sleep-wakefulness patterns. Growth hormone is released primarily during the early part of the night and its secretion is enhanced by delta sleep. Sleep also stimulates prolactin secretion, although prolactin peaks after growth hormone, usually during the middle portion of the night. Pulses of growth hormone and prolactin can occur after the onset of sleep, regardless of its timing. In contrast, thyroid-stimulating hormone reaches its peak level in the evening just prior to sleep onset. Its secretion is inhibited by sleep and stimulated by sleep deprivation. The hypothalamic pituitary adrenal axis is usually at its most inactive state at nocturnal sleep onset. Sleep onset inhibits cortisol release, whereas adrenal corticotrophic hormone and cortisol levels rise at the end of the sleep period, shortly before awakening, and likely contribute to morning arousal. Severe sleep disruption or sleep deprivation may have significant clinical effects on the endocrine system. For example, patients with obstructive sleep apnea show decreased levels of growth hormone and prolactin, and sleep deprivation produces evidence of hypothalamic pituitary adrenal axis activation in the evening of the day following deprivation. One of the characteristics of REM sleep is the occurrence of penile erections. Nocturnal penile tumescent studies are therefore helpful in determining whether cases of impotence are related to organic or psychogenic etiologies. In women, REM sleep produces increased vaginal blood flow and clitoral erection. These changes are not necessarily linked to sexual content in associated dreams. The cyclical nature of sleep is regular and reliable. A REM period occurs about every 90 to 100 minutes during the night. The first REM period tends to be the shortest, usually lasting less than 10 minutes. Later REM periods may last 15 to 40 minutes each. Most REM periods occur in the last third of the night, whereas most stage 4 sleep occurs in the first third of the night. These sleep patterns change over a person's lifespan. In fact, age is probably the single most crucial factor apart from the time since the last episode of sleep that determines how humans characteristically sleep. More so than gender, psychiatric illness, and even, to a large extent, most physical illnesses, age is a major determinant of human sleep. In the neonatal period, REM sleep represents more than 50% of total sleep time, and the EEG pattern moves from the alert state directly to the REM state without going through stages 1 through 4. Newborns sleep about 16 hours a day, with brief periods of wakefulness. By 4 months of age, the pattern shifts so that the total percentage of REM sleep drops to less than 40%, and entry into sleep occurs with an initial period of NREM sleep. Stages 3 and 4 of non-REM sleep, that is, synchronized, delta wave sleep, slow wave sleep, show a steady decrease across the lifespan. By 3 to 5 years of age, children typically have abundant, high-amplitude synchronized delta wave sleep, which is relatively impervious to noise and external disruptions. Beginning in early adolescence, there is a gradual decline in delta wave sleep. This decline continues throughout adulthood. By young adulthood, the distribution of sleep stages is as follows. Non-REM is 75%. Stage 1, 5%. Stage 2, 45%. Stage 3, 12%. Stage 4, 13%. While REM is 25%. This decrease in stages 3 and 4 sleep is generally replaced by non-REM stages 1 and 2. By the time the average human reaches age 75, stage 4 sleep, the sleep with the most abundant delta waves, may be virtually absent. The functional significance of the age-related decline in human delta activity during sleep is unknown, but the decline may represent one of the earliest known indicators of the aging of the central nervous system. Based on the National Sleep Foundation recommendations for sleep. In each group, the guidelines present a recommended range of nightly sleep duration for healthy individuals. In some cases, sleeping an hour more or less than the general range may be acceptable based on a person's circumstances. Other factors which influences the increased sleep need are with physical work, exercise, illness, pregnancy, general mental stress, and increased mental activity. Sleep is essential for many vital functions including development, energy conservation, brain waste clearance, modulation of immune responses, cognition, performance, vigilance, disease, and psychological well-being. Without external clues, the natural body clock follows a 25-hour cycle. The influence of external factors, such as 1. The light-dark cycle. 2. Daily routines. 3. Meal periods. 4. Biological rhythm, and 5. Environmental factors. These follows persons to the 24-hour clock cycle. However, when person is deprived of sleep, it may result in negative consequences. So, what are these consequences? At first, sleep deprivation may cause minor symptoms, but over time these symptoms can become more serious. Initial sleep deprivation symptoms may include drowsiness, inability to concentrate, impaired memory and cognition, reduced physical strength, and diminished ability to fight off infections. Prolonged sleep deprivation may include increased risk for depression and mental illness such as ego disorganization, hallucinations and delusions or severe mood swings, increased risk for stroke, heart disease, asthma attack or obesity, increased risk for potentially life-threatening complications, such as car accidents, and untreated sleep disorders like insomnia, sleep apnea, and narcolepsy. In addition, depriving persons of REM sleep by awakening them at the beginning of REM cycles increases the number of REM periods, and the amount of REM sleep causes an increased rebounds, when they are allowed to sleep without interruption. This results to irritability and even lethargy. Sleep is regulated by several mechanisms, and when these mechanisms are not normally regulated, sleep disorder occurs. The 5th edition of the Diagnostic and Statistical Manual of Mental Disorders (DSM-5) of the American Psychiatric Association lists 10 disorders or disorder groups as sleep-wake disorders on the basis of clinical diagnostic criteria and presumed etiology. Today, I will be briefly discussing only the commonly occurring sleep disorders. Based on the DSM-5, insomnia disorder refers to dissatisfaction with sleep quantity or quality associated with difficulty in initiating or maintaining sleep. These are often associated with frequent early awakenings. 1-year prevalence rate, 30–45% in adults. It is categorized in terms in A. How it affects sleep. B. Duration, either transient or brief, persistent, idiopathic or primary. Transient is most often associated with anxiety, which is either a sequela to an anxious-provoking experience such as examination, job interview, grief, loss or any life-changing stress. This is not likely to be serious and resolved without the need for medication. However, monitoring should still be observed if this is accompanied with psychotic or depressive episode, because this conditions begin sometimes with acute insomnia. Long-term or persistent is associated with somatized tension, anxiety with a condition-associative response. Patients have no clear complaints except insomnia. They may not experience anxiety per se but discharge the anxiety through psychological channels such as manifested through ruminative thoughts or preoccupations, and sometimes describes these conditions due to stress at home or work. This can be manifested either as 1. Sleep state subjective insomnia. There is a dissociation between the patient's subjective experience of sleeping and the polygraphic measures of sleep. Cause is unknown, but it is usually seen in patients with somatic delusions or illness, anxiety disorder triggered by high level of stress. 2. Psychophysiological or conditioned insomnia. Patient reports having difficulty in sleeping for years and denies that it is related to life stressful changes. Objects associated with sleep like pillow or bedroom became a conditioned stimuli that evoked the insomnia. It is usually seen in anxiety disorders and drug withdrawal and is usually manifested by A. Excessive worrying of not being able to sleep. B. Trying too hard to sleep. C. Ruminating thoughts, inability to clear one's mind while trying to sleep. D. Increased muscle tension when going to sleep. E. Somatic anxiety. F. Being able to sleep when not trying, and G. Being able to sleep when away from bed. C. Idiopathic insomnia, starts early in life, usually at birth, and continues throughout life. The cause is unknown, but it is suspected that it may be due to neurochemical imbalance in the brainstem reticular formation, impaired regulation of the brainstem sleep generators, or basal forebrain dysfunction. D. Primary insomnia is diagnosed if the chief complaint is non-restorative sleep or difficulty in initiating or maintaining sleep with repeated awakening associated with increased physical and psychological arousal that which occurred at least 3x a week. It persists for at least 1 month or more, according to ICD-10. This not due to any general medical condition or drug-induced which cause impairment in personal, occupational and social function. Preoccupied of not getting enough sleep leads to the more they try to sleep, and the more they are frustrated and distressed, which leads to the more the sleep disturbance. Pharmacologic treatment are the following. A. Benzodiazepine, a standard treatment to treat insomnia. For example, long-acting, fludiazepam, diazepam, is good for night insomnia and maintaining sleep. B. Non-benzodiazepines such as zolpidem, is a short-acting drugs that are helpful for person who have difficulty initiating sleep. It is considered as hypnotic drugs and are only recommended to be used not more than 2 weeks because of tolerance and withdrawal may result. It is not recommended for long-term treatments. C. Melatonin receptor agonist, for example Rameltine is good for sleep onset insomnia. Melatonin is an endogenous hormone produced in the pineal gland to regulate sleep. D. Sedating antidepressants, for example trazodone or Deseril is an antidepressant which has a high sedating properties, alpha-1 adrenergic blockade which decreases sleep onset latency and improves sleep efficiency. Two. Non-pharmacologic approaches are, A. CBT, the goal is to overcome dysfunctional sleep behaviors, cognitive distortions or misperceptions and disruptive thoughts about sleep. Behavioral approaches include sleep hygiene, stimulation control therapy, sleep restrictions, relaxation therapies and biofeedback. Here are the do's and don'ts for good sleep hygiene taken from Kaplan. Please review this later. Stimulus control therapy. The aim of this approach is to break the cycle of problems commonly associated with difficulty initiating sleep by undoing the stimulus or factors responsible for sleeplessness. It is followed by 3 rules which needs to be consistent. 1. Go to bed only when sleepy. 2. Use the bed only for sleeping, do not eat, talk, read when in bed. 3. Do not lie in bed and be frustrated when not able to sleep. Do not watch the clock. The goal is to associate the bed with rapid sleep onset. The next one is sleep restriction therapy. The goal is to increase sleep efficiency. It is the time asleep as a percentage of the time in bed, by decreasing the amount of time spent awake while lying in bed. So when the sleep efficiency reaches 85% with an average over 5 nights, time in bed should be increased by 15 minutes. This therapy when done properly produces a gradual and steady decline in nocturnal wakefulness. The third one is relaxation therapy and biofeedback, includes breathing exercise, guided imagery and progressive muscle relaxation to find the optimal technique of relaxation. In progressive muscle relaxation, this is helpful to persons who has always muscle tension. It purposefully tense their muscles for 5-6 seconds then relax for 20 to 30 seconds which begins in the head down to the lower extremities. This is to identify the difference of tension and relaxation. Guided imagery is by picturing a pleasant relaxing scenes based on the senses. Breathing exercises should be done 20 minutes per day for 2 weeks then once mastered used in bedtime for 30 minutes the last one. Biofeedback which provides stimulation cues for physiological markers for relaxation to increase self-awareness. Based on the DSM-5, hypersomnolence disorder is characterized by a self-reported excessive sleepiness despite a main sleep period lasting at least 7 hours, with at least one of the following symptoms: a. Recurrent periods of sleep or lapses into sleep within the same day. B. A prolonged main sleep episode of more than 9 hours per day that is non-restorative and unrefreshing. C. Difficulty being fully awake after abrupt awakening. The sleepiness is a consequence of either of the following: inadequate sleep, a basic neurologic dysfunction in the brain systems regulating sleep, disrupted sleep or a disturbance of the patient's normal circadian rhythm. B. The hypersomnolence occurs at least 3 times per week, for at least 3 months. C. There is impairment in cognitive, social, occupational or important areas of functioning. D. It is not better explained by and does not occur exclusively during the course of another sleep disorder. E. It does not due to another coexisting mental disorder. F. It is not due to a physiologic effect of a substance. Sleepiness affects attention, concentration and memory in high-order cognitive process. The effect usually affects failure at school, loss of employment, MVA and industrial disasters. Conditions associated with hyperstimulants are the following. A. Klein-Levin syndrome. B. Behaviorally induced insufficient sleep syndrome. C. Hypersomnia due to another general medical condition. D. Hypersomnia due to drug or substance use. Treatment are A. Regularizing sleep-wake schedule. B. Lifestyle change. C. Giving an SSRI, as it reduce and eliminate REM sleepiness, preventing daytime sleepiness. Based on the DSM-5 criteria of narcolepsy. A. Recurrent episodes of irrepressible need to sleep, lapsing into sleep or napping in a day, occurring at least 3 times in a week for the past 3 months. B. The presence of at least one of the following. 1. Episodes of cataplexy as manifested by either brief episodes of sudden bilateral loss of muscle tone with maintained consciousness which is then precipitated by laughter or joking, or spontaneous of grimaces or jaw-opening episodes with tongue thrusting or global hypotonia with any emotional triggers. 2. Hypocretin deficiency measured by CSF hypocretin-1 immunoreactivity. 3. Nocturnal sleep polysomnography, showing REM sleep latency of less than or equal to 15 minutes, or a mean sleep latency of less than or equal to 8 minutes in a 2 or more REM sleep periods. In fact, the condition is due to disturbance in REM inhibiting sleep mechanism. The REM sleep is characterized by either hypnagogic or hypnopompic hallucinations, cataplexy, and sleep paralysis. It can be dangerous in driving and usually causes motor vehicular accidents. It occurs in about 0.02 to 0.16% of adults before age 30 years old in general population and has a familial incidence. The most common symptom is sleep attacks, which is often associated with cataplexy, account to 50% of most cases. The classic form, narcolepsy with cataplexy, is characterized by tetrad of symptoms. They are excessive daytime sleepiness, cataplexy, sleep paralysis, hypnagogic hallucinations. Treatment-wise, there is no cure exist for narcolepsy, but symptom management is possible. They are 1. A regimen of forced naps at a regular time of the day helps patient with narcolepsy even without medication. Other non-pharmacotherapeutic approaches include lifestyle adjustments, psychological counseling, drug holidays to reduce tolerance, monitoring of cardiac status. 2. Stimulants are used as pharma treatment. 3. Modafinil, alpha-1 adrenergic agonist, helps reduce number of sleep attacks and improve psychomotor performance. Just monitor tolerance, which is one of the side effects of the drug. And lastly, SSRI or imipramine, helps reduce cataplexy where it suppresses REM sleep, as cataplexy is due to intrusion of REM sleep into awake state. Sleep-disordered breathing includes conditions ranging from upper airway resistance syndrome to severe obstructive sleep apnea. Sleep-related breathing impairments such as apnea and hypopnea are most often caused by airway obstruction. However, sometimes respiratory reduction results from central brainstem changes in ventilatory control, metabolic factors, or heart failure. Each sleep-disordered breathing event can be classified as central, obstructive, or mixed. A. Obstructive sleep apnea, hypopnea, or OSA. It is a repetitive collapsed or partial collapse of the upper airway during sleep, usually in supine position. As person is sleeping, airway resistance increases, which increase respiratory effort. airway occlusion or obstruction period occurs, which then result to a decrease in arterial oxygen saturation, leading to transient arousal state and respiration continues normally. During an obstructive apnea episode, respiratory effort continues but airflow ceases due to loss of airway patency. A reduction in breathing for 10 seconds or hypopnea may lead arousal and sleep fragmentation. A reduction of ventilation results to a decrease in oxyhemoglobin concentrations as noted in polysomnogram. Predisposing factors for OSA are the following. 1. Male, middle age, obese, micrognathia, a malocclusion of the maxilla or mandible, nasopharyngeal abnormalities, hypothyroidism, acromegaly. The clinical features of OSA are excessive sleepiness, snoring, obesity, restless sleep, nocturnal awakenings or choking or gasping for breath, morning dry mouth, morning headaches, and heavy nocturnal sweating. Patients may also have hypertension, erectile failure in men, depression, heart failure, nocturia, polycythemia, and memory impairment as a result of obstructive sleep apnea-hypopnea. Obstructive apnea and hypopnea episodes can occur in any state of sleep but are more typical during REM sleep, non-rapid eye movement stage 1, and non-REM stage 2 sleep. Treatment for OSA, A. The continuous positive airway pressure therapy is the treatment of choice. To maintain a patent airway, weight loss strategies should be employed. Drug therapies alone have been tried but without success. Pharmacologic treatment, 1. Theophylline, reduces apnea but further study is needed. 2. Modafinil, is approved for OSA as wake-promoting substance however does not treat the obstruction itself but used as an adjunct for treating residual sleepiness along with CPAP therapy. B. Central sleep apnea. Define as absence of breathing due to lack of respiratory effort or failure of the CNS mechanism to stimulate breathing. It is a disorder of ventilatory control in which repeated episodes of apneas and hypopneas occurring in periodic or intermittent pattern during sleep. The following are the difference between OSA and central sleep apnea. Please review this. In the CSA polysomnogram findings, it is similar to OSA however during periods of apnea, a cessation of respiratory effort is seen in abdominal and chest expansion leads in CSA. A characteristic breathing known as Cheyne-Stokes breathing is seen, which is a prolonged hyperpnea during which the tidal volume wax and wane in a crescendo-decrescendo fashion. Which means, the hyperpnea is alternated by periods of apnea and hypopnea. Reduced in ventilatory effort. Common in older men with CHF or stroke. Circadian rhythm sleep disorder. This is a collection of several conditions which are due to irregularities between desired and actual sleep periods. A desynchronization between a person's actual circadian biological clock and the desired sleep-wake cycle. The circadian pacemaker is located in the suprachiasmatic nucleus of the hypothalamus, normally resets on a daily basis which is affected by light day, social cues, stimulants or activity. DSM-5 lists 6 types of circadian rhythm sleep disorders: delayed sleep phase type, advanced sleep phase type, irregular sleep-wake type, non-24-hour sleep-wake type, shift work type and unspecified type. Here are some brief descriptions. A. Delayed sleep phase type occurs when the biological clock runs slower than 24 hours than the desired schedule, which results to a delay in your sleepiness-alertness cycle. Persons with this condition are more alert in the evening, early nighttime, thus they stay awake later at nights and very tired in the morning. They are called night owls. B. Advanced sleep phase type occurs when the biological clock runs faster than 24-hour than the desired schedule, which results to a faster or early sleepiness equal alertness cycle. Persons are drowsy in the evening and more alert in the morning. They are called early bird. C. Irregular sleep-wake type occurs when the biological clock is absent or pathologically diminished or disorganized and the desired sleep-wake cycle is unpredictable. Persons have normal sleep of 24-hour, however fragmented into 3 more episodes. There is insomnia at night and tiredness when waking up in the morning. Daytime sleepiness is also evident. Thus, daytime naps and nocturnal wakefulness occur. Activities of daily life sometimes are affected. This condition is usually associated with neurodegenerative disorders such as ADD and neurodevelopmental disorders in children. D. Non-24-hour sleep-wake type occurs when the circadian pacemaker has a cycle length of more than 24-hour and is not reset in the morning. Usually seen in blind or visually impaired persons, traumatic brain injury, as there is no resynchronization of the circadian rhythm occurring daily in response to light-dark cycle. Treatment for this is phototherapy and melatonin. E. Shift work type occurs in persons who are doing shift work. This people usually suffered from insomnia when going to sleep, excessive sleepiness when staying awake, or both. Some people requires only short time to adjust to a shift change, whereas others have great difficulty adjusting. They usually adopt a non-shifted sleep-wake schedule on weekends and holidays. Because of this leads to sleep deprivations. The circadian rhythm continues to poorly adjust to the sleep-wake schedule. The natural low point in the normal sleep-wake cycle rhythm occurs at 3 to 5 a.m. The time where most accidents usually occurs due to sleepiness. F. Jet lag type is still recognized as a circadian rhythm sleep disorder. There is desynchrony between circadian and environmental clock. This is usually experienced when a person travels across time zones. Either a circadian phase advanced or delay occurs depending on the direction of the travel. Normally, person can adapt easily to 1 or 2 time zones per day, but to those individuals who travel for business more than will experience jet lag. G. Due to medical conditions/drugs, may also affect sleep regularities. Seen in patient which is bedridden in the hospital, ICU patients who have chronic debilitating diseases, dementia or amphetamine addicts. Treatment are the following. 1. Chronotherapy, technique used to reset the biological clock. It is done by progressively delaying a person's until circadian oscillator is synchronized with the sleep-wake schedule. 2. Light therapy, it is exposing the person to bright light of 10,000 lumens lasting to about 20 to 30 minutes to phase advanced with delayed sleep phase syndrome early in the morning or in the evening. And lastly, melatonin, a sleeping substance. Levels is high in dusk till dawn but lowers down in the morning, thus bright light suppresses melatonin secretion. Parasomnias. These are disorders of partial arousals characterized by physiological or behavioral phenomena that occur during or potentiated by sleep. They are classified as NREM sleep arousal disorder and related to REM sleep. Among the non-REM disorders are either accompanied by sleepwalking or sleep terror, while the related to REM sleep is sleep paralysis. Based on the DSM-5, non-REM sleep arousal disorders. A. Recurrent episodes of incomplete awakening from sleep occurring during first third of a major sleep episode accompanied by either one of the following: sleepwalking or sleep terror. For example, sleepwalking are repeated episodes of rising or ambulating from bed during sleep and walking about. It occurs during delta sleep, thus person is difficult to awaken. If forcefully awaken, person are confused. commonly seen in children 4-8 years old and disappears during adolescence. Sleep terror are recurrent episodes of abrupt terror arousal from sleep, usually exhibiting a panic scream occurring in stage 3 and 4 sleep period. The intense fear and anxiety are due to autonomic hyperactivity. When person is awake, they are disoriented, incoherent, and amnesia is present. B. No or little dream imagery is recalled. C. Amnesia for the episode is present. D. It causes clinically significant distress or impairment in social or occupational functioning. E. It is not due to a physiologic effect of a substance or other coexisting mental or medical disorders. Sleep disorder related to REM sleep. A. Recurrent isolated sleep paralysis. There is inability to make involuntary movements, which is very distressing during sleep. It becomes a parasomnia when it occurs at sleep onset or awakening. This is the time when the patient is partially conscious and awake of the surroundings. It is one of the symptoms of narcolepsy. Condition which increases the likelihood of sleep paralysis includes A. Irregular sleep. B. Sleep deprivation. C. Psychological stress. D. Shift work. Sleep paralysis occurs in 7-8% of young adults and terminates if someone touched the person. Treatment: sleep hygiene and assurance of sufficient sleep. B. Nightmare disorder. It is characterized by frightening or terrifying dreams leading to anxiety attack due to sympathetic activation. It occurs in REM stage, and when the person awakes, he can remember the dream, in contrast to sleep terrors. Frequent nightmares produces a fear of sleeping type of insomnia, which produces sleep deprivation and exacerbates nightmare. This is usually seen in post-traumatic stress disorders and common in children ages 3 to 6 years old, seen in 10 to 50% of most cases, but rare in adults 1%. Drugs which provokes nightmares includes A. L-DOPA. B. Adrenergic blockers. C. Alcohol and drug abuse. Treatment includes sleep hygiene, stimulus control therapy, lucid dream therapy, cognitive therapy. In PTSD, antidepressant nifazodone or benzo may be helpful, and prozosine, an alpha-1 adrenergic antagonist, increased total sleep time and REM sleep, reducing nightmares and distressed awakenings. Other parasomnias. Sleep ineresis or bedwettings, which is common in children. It has two forms: A. Primary, continuance of bedwetting during infancy. B. Secondary, relapse during toilet training was complete at 6 years old and there was a period when the child remained dry. Prevalence occurs in drops at 30% at age 4, 10% at 6 years, 5% at age 10 and 3% at age 12 years old. If persist to adult, may lead to psychosocial scars. In most cases, embarrassment, guilt and shame is the serious consequences. Treatment: aripiprazole, synthetic vasopressin or ozibutylene chloride, which is an anticholinergic and antispasmodic to treat irritable bladder. And behavioral therapies such as bladder training, fluid restriction, motivational therapy. Sleep-related movement disorder. A. Restless leg syndrome, ECPAM syndrome, is an uncomfortable sensation of the limbs, usually the legs, described as creepy crawly feeling, an irresistible urge to move the legs when at rest or trying to go to sleep. It is worse at night and moving the legs helps alleviate the discomfort. It is characterized by profound insomnia. Patient with iron deficiency anemia and folic acid deficient can produce secondary RLS. RLS is associated with fibromyalgia, RA, DM, thyroid diseases and COPD. Treatment of choice is pramipexole, a dopamine agonist for Parkinson's disease and roperidol. Can also give benzo, opiates, antiepileptics like gabapentin. Avoid alcohol, massage parts of the legs, taking hot baths, moderate exercise are helpful. B. Sleep-related leg cramps, occurred during wakefulness, usually affects the calves, and painful muscle contractions. It awakens the sleeper and disrupts sleep. Other precipitating factors includes DM, metabolic disorders, mineral deficiency, electrolyte imbalance, and pregnancy. C. Bruxism. The individual grinds and clenches teeth during sleep, which products damage to the teeth, or jaw pain which disturbs the partner. Sometimes can produce headache or facial pain. It is common to general population, accounting to more than 85%. Teeth grinding can occur in any sleep stage, but most common in transition to stage 2 sleep and during REM sleep, triggered during time of stress. Treatment includes the person wearing a protective appliance to protect the teeth during sleep, like mouth guard for short-term use or mouth splint for longer-term use. Relaxation, biofeedback, stress management. Drug treatment are BZD, muscle relaxants, propranolol, dopamine agonists. Isolated symptoms and normal variants. A. Long sleeper, person sleeps 10 to 12 hours and feels refreshed, seen in childhood. B. Short sleeper, person sleeps less than 5 hours of sleep in order to maintain a daytime function and mood. This is genetically influenced but still unknown. C. Snoring, presence of loud noises in the absence of recurrent apnea or hypopnea episodes. D. Sleep talking or somnambulism, involves unconscious speech during sleep. It can be induced by fever, stress, or conversing with the sleeper. This may accompany sleep terror, confessional arousals, OSA, REM sleep disorders. E. Sleep start or hypnic jerks, a sudden, brief muscle contractions, which occur in between transition between wakefulness and sleep in 60 to 70% of patients. The contraction usually affects the leg, arms, or head. It is benign, accompanied by sensation of falling, hallucinatory flash of lights, or loud cracking sound, resulting to a profound onset sleep insomnia. F. Environmental sleep disorder, due to environmental factors like noise, heat, cold, bed partner noise, which produces insomnia or hypersomnia. Treatment: remove the environmental irritant stimuli. Here are my references for this lecture. Thank you for listening. This concludes my course lecture series about this topic.